Good afternoon, everyone. My name's Warren Boykin, and I'm uh, here at NAMI Northern Illinois. I'm welcoming you to today's Leading the Conversation with our special guest, Eva Zeidner. She's going to introduce the topic, Understanding Psychosis, Recognizing the Signs and Supporting Early Intervention for Providers. Just a quick word about CEUs. After the presentation, you will be emailed an evaluation form. And for those who stay for the entire presentation, if you return that evaluation form to us, then we will send the CEU information to you. So without further ado, turn it over to you, Eva. Thank you for being here.
Thanks, Warren. And thank you, everyone in the audience, for attending today. Um, as Warren said, my name is Eva Zeidner. I am with the Thresholds Emerging Adult Program. Thresholds is one of the largest community mental health organizations in the state of Illinois. I oversee community relations and clinical assessment. So essentially, overseeing intake and doing things just like this to spread information about our services. I've been in the mental health field for over 30 years. I have a couple of my own young adults in my life, and so I have some street cred in terms of my um, understanding of both working with young people and with working with serious persistent mental health conditions. So today's workshop, we're going to be focusing on a number of things. I want to very quickly overview the diagnosis of psychosis, as well as clinical high risk for psychosis, and talk about the signs and symptoms of each to make sure that we're all on the same page. I want to make sure that everyone understands assessment for these diagnoses and how to address talking with clients and their families when you want to pursue a more specialized type of assessment. Oftentimes, just the discussion can be anxiety provoking. So I think it can be helpful to talk about talking points. I want to teach you a little bit about the coordinated specialty care model, which is the evidence-based practice for treating early psychosis, about how that was adapted to treat clinical high risk for psychosis, which is essentially identifying people who are in the prodromal phase. And then I want to consider some interventions that you all can provide in your practice, and probably are already to a certain degree providing, but help you have a greater understanding of how and why these are suitable for individuals struggling with these serious symptoms. What is psychosis? Well, we know it's a complex medical condition that interferes with a person's experience with the world. Individuals have difficulty discerning reality, and this loss of contact causes significant disruption in an individual's ability to function. When we're talking about psychosis in the first part of the presentation, we're going to be focusing on this active phase where positive symptoms have emerged. Positive symptoms meaning these added on symptoms, namely hallucinations, most commonly hearing voices or seeing things, but really anything that impacts an individual's perceptions. So there have been people I've known with olfactory hallucinations, who've tasted things strangely, who felt tactile sensations on their skin. In addition, delusional thoughts, those false or bizarre beliefs that make sense to a person, but those who are part of their support network, who know the circumstances and the situation, might consider them to be implausible. Confused thinking, that includes disorganized thoughts or speech, difficulty concentrating and understanding others, oftentimes impacting both an individual's ability to receive communication and understand it, as well as to articulate their thoughts clearly. And overall, as I already stated, this leads to a very substantial disruption in one's life. Psychosis is more common than you might think. 3 out of 100 people, so 3% of the general population experiences psychosis at some point in their lives. And 75% of those diagnoses and those first episodes occur by the age of 24. When we're talking about psychosis today, we're going to be focused on psychosis as a symptom. So it can occur associated most commonly with schizophrenia and the schizophrenia spectrum disorders, but also with affective disorders like bipolar disorder, major depression, and at times is associated with trauma and other diagnoses. So we're going to take this broad approach to understand psychosis as it's associated with any diagnosis. Some of the risk factors that have been identified include simply being young. There's a reason that the first episode program at Thresholds is housed within the emerging adult program, where we're working with people in their late teens to early 20s. That age range from about 12 to 30 is when most people will experience their first symptoms if it's going to happen. We know that having a family history of a psychotic disorder, particularly of a parent or a sibling, also increases the risk. Having a history of difficulty making friends, having unusual thoughts, and eccentric behaviors has also been identified as a potential risk. And there's a growing research base for the role of trauma, particularly complex trauma that has spanned over the course of one's lifespan, but also sometimes acute trauma after something really significant happens. A person can have a brief episode. When we talk about psychosis, we talk about the stress vulnerability model. And while this is a very simplistic notion, it's a key point to make. And we will touch on it again later in the presentation when we're talking about psychoeducation. This notion of stress vulnerability is the idea that individuals have biological vulnerability towards mental health diagnoses as well as medical diagnoses. When we add to that stressors, we know that potentially that can lead to symptoms. So the idea of biological vulnerability, obviously, if you have family members who have struggled with symptoms, you know that you have that vulnerability, but we are not always aware of that. Just like there could be an individual who has a very healthy family, might be very physically active and fit, and then we hear that perhaps they've suffered a heart attack. Sometimes one might not be aware that you have a cardiac problem. So the same is true for biological vulnerability of psychotic disorders. Stressors added to that, again, stress is something that's subjective. So what is stressful to me might not be stressful to another individual. And something that I've noted over the many years that I've worked with young people who are struggling with psychotic disorders is that oftentimes they are not as open to and aware of the stress factors in their own lives. So they're not open to perhaps identifying them as stressors. They're more likely to want to repress those feelings or deny the fact that these things are a struggle for them. And so when we're working with individuals, this idea of helping people to better understand the impact of stress on themselves and recognize this as the one area that we actually have an opportunity to make changes in terms of how we both respond to stressors and identify them is really key in terms of the overall treatment. So we're going to return to this idea later, but I wanted to make sure that I explained why this is so significant, even though, as I said, on the surface, it appears to be fairly simplistic. We know that early intervention matters. There has been a lot of research indicating that the longer an individual's symptoms persist, the less likely that treatment will be effective in terms of how an individual responds and in terms to long-term outcomes. So we don't want to ignore symptoms, and we know that early identification is key. In the United States, the average individual goes for 17 months with no intervention after they've begun experiencing positive symptoms, so those hallucinations and delusions. With that in mind, we want to think about this early intervention paradigm. the idea that early detection with an aggressive treatment during this critical period leads to improved outcomes. Those outcomes include things like decreasing the severity and frequency of symptoms, decreasing and possibly even preventing the need for inpatient treatment and hospitalization, increasing participation in work and school, and then overall, these things leading to an improved quality of life. So, we know that early identification is key, and we've been talking about this period when positive symptoms emerged. One of the things that we want to consider is, can we identify individuals who are at risk for these more serious symptoms? And can we provide interventions that might be helpful either in preventing or minimizing the impact of developing psychosis? And so in this slide, you see a progression of a psychotic disorder. Initially, there's that latent risk, the risk that we might have some idea that there's vulnerability there and we might not. And then there's this phase that's highlighted on the screen where it says clinical high risk for psychosis. If an individual had already developed psychotic symptoms, we would call this the prodromal phase. But we cannot use the term prodromal if an individual has not yet had symptoms. So the term clinical high risk for psychosis was coined to identify a phase during which an individual might begin to show symptoms that indicate they are at risk for developing positive symptoms of psychosis. At the very start of this risk phase, negative symptoms emerge, and at some point midway through, attenuated symptoms emerge. And I want to talk in a little bit more detail about negative and attenuated symptoms so that we can think about how we might be able to identify individuals who are in this risk phase and begin to provide some interventions then, as well as thinking about the treatment that is recommended for individuals once they've developed positive symptoms. Negative symptoms of psychosis, negative meaning the lack of or decline in things like motivation, energy, ability to enjoy things in your life that you formerly enjoyed, lack of focus or attention, using fewer words, actually speaking less, a flattened out emotional kind of presentation, and increased isolation, less social functioning, spending fewer time with family and friends. All of these things, as you all probably know, are also signs of depression. So for many individuals who are in this clinical high risk phase, they might have sought out treatment and be actively engaged in treatment for depression. Depression and negative symptoms are not interchangeable words. They're just presentations that are very, very parallel and mirror each other. So it's confusing at this point. The reason it's important to consider this is that if we are treating someone who is struggling with very serious symptoms of depression that look like the ones that are outlined here on the screen, we want to always continue to monitor and assess for the possibility that they might be at risk for more serious symptoms like psychosis. The word attenuated simply means having been reduced in force, effect, or value. So we're talking about attenuated positive symptoms of psychosis. Essentially, these can be unusual thoughts, sensory experiences, or perceptual changes, and individuals experiencing them are still able to discern reality from fantasy. We're talking about things like seeing shadows, hearing sounds like a very, very quiet whispered conversation, or banging or knocking or hissing, perhaps even one's name being called, increased sensitivity to light or sound. And an individual might attribute these things to their mind playing tricks on them. Just earlier this morning, I was talking to a father whose son is reporting that he sees raindrops when he knows that there is no rain there. And he's seeing like lightning kind of coming out of his fingertips at times, and he knows that this isn't happening. I think that those things are examples of attenuated symptoms. Let's talk about what this clinical high risk state might look like to a family member or a provider who's working with an individual. We know that there are mood changes, increased depression or anxiety, lack of energy, decreased pleasure in formerly enjoyable activities. All of these things kind of reflect those negative symptoms that I was just talking about. Also, we know that there's this decrease in an individual's ability to function in their day-to-day life. We also know that there are behavioral changes like social withdrawal, decrease in attention to hygiene and personal appearance, perhaps not to the degree that we would see in active psychosis when positive symptoms are present, but something that is to a slightly lesser degree. For instance, an individual who formerly was very focused on putting together outfits that were coordinated, perhaps wearing accessories, styling their hair, wearing makeup, and then transitioning maybe to wearing sweats every day and kind of looking disheveled and rumpled. And again, a decrease in functioning overall. There's a cognitive decline that leads to having difficulty with concentration, memory, and completing tasks. And then overall, this usually leads to disruption in work and school functioning. So again, that decrease in ability to function. There are unusual sensory experiences or perceptual changes, and the individual questions the reality of these. So these are those attenuated symptoms that I was talking about. Seeing shadows, hearing knocking or banging sounds, or barely audible conversations, one's name being called, or that increased sensitivity, all attributed to one's mind playing tricks. So the person can still discern reality, though that line is getting fuzzier. Some examples, I have had young people tell me things like, my mom left for work, and yet I went into the shower and could hear her calling my name, and I knew that she wasn't in the house. Or someone else shared with me that she was hearing what sounded like a barely audible conversation that she was quite certain wasn't real, but she even went over to like the window to check and see if there were people outside who were talking. We know that there can be increased suspiciousness, paranoia, or grandiose ideas. And again, not to the degree of a full delusional thought, but something that, again, can be questionable. Sometimes this can be difficult, particularly when we're talking about a young adult or a teen, where there might be periods of time where individuals, for instance, change friend groups or have falling outs with people. I have had parents report in hindsight that their young person who experienced a first episode a couple of years earlier had been accusing family members of poking fun at them and making fun at them, of pulling away from close friends from the past, feeling that they could no longer trust those individuals. So this can be something that's difficult to assess in the moment, but when you see it occurring as a parallel to some of these other things I've talked about, that's when you want to take a closer look at it. We know that there's that biological connection. Having a first-degree relative, that means either a parent or a sibling, diagnosed with a psychotic disorder increases psychosis risk from 3% to 10%. So it doesn't mean that an individual is definitely going to experience the symptoms. It just means that their risk is slightly higher. One of the things that's important to note is that of the individuals who meet criterion for this clinical high risk state, only 1 out of 4, approximately 22%, go on to develop active psychosis. We don't know which ones that they will be. So when we're thinking about identifying individuals at risk and providing services, we want to think about services that in no way would ever potentially cause harm to an individual. And we also want to make sure that we are communicating and not that this is a risk state and does not mean that an individual will definitely develop psychosis. These statistics come from data that was collected when Thresholds was part of a grant to develop clinical services for individuals at clinical high risk for psychosis. We were one of 22 sites that were scattered throughout the United States who received this grant. There had been a lot of research done on this risk state, but clinical services had not been offered. So the grant asked each site to basically address, how they would provide services. We adapted the coordinated specialty care model that I'm going to talk about in a moment. When we started at the beginning of our 4-year grant, the statistic was actually 1 out of 3 people developed symptoms based on what the research had been done to date. After additional data was gathered, we knew that something we were doing was actually providing a positive gain because the statistic moved from 1 out of 3 to 1 in 4. It's important to take note that an individual experiencing attenuated symptoms, those symptoms where they're feeling like their mind's playing tricks on them, if they have a prior history of psychosis, even if it was many, many years ago, we would consider this person at risk of relapse. The term clinical high risk for psychosis is utilized only for individuals who have never had prior psychosis. So these are still very important things to pay attention to and to address because we do not want someone to have a relapse, but we don't use the same terminology. In the DSM-5, attenuated psychosis syndrome, or APS, which is what is diagnosed if someone meets criterion for clinical high risk, falls under the category of other specified schizophrenia spectrum and other psychotic disorder, or F28. And it's considered a condition for future study. So it's diagnosable and it's identified, but the condition is still being researched, and at some point it might be identified as its own standalone diagnosis. Right now, it's grouped under F28. How do you address the need for more detailed assessment with clients and their families if you have concerns? As I noted at the start of the presentation, this can be a very sensitive area to address. And so a few talking points that our program identified include things like making sure that people understand that identified with a risk state does not mean that individuals will develop psychosis. Most people, 3 out of 4, in fact, do not. For many people, symptoms will totally go away. For some, they might stay the same, and we just want to provide increased understanding. And for some people, that 1 out of 4, they could get worse. We want to make sure that individuals and their families know that no one is to blame. They did not cause this clinical high risk state. This is where explaining biological vulnerability definitely comes into play. And we want to emphasize that early intervention helps to prevent symptoms from getting worse. So rather than individuals becoming alarmed by this and withdrawing, pulling away from treatment, we want to help them feel more comfortable with the idea of learning more. And we want to make sure that individuals recognize that they are not alone, that this is a situation that is of such importance that there's a lot of research done on it, and in fact, services that are specifically designed to help people. How is clinical high risk identified? So initially, the SIPS, or Structured Interview for Psychosis Risks Syndromes, was developed at the Yale School of Medicine's Prime Research Clinic. Structured interview is a tool that clinicians and researchers use to understand someone's experiences, thoughts, and symptoms by asking the same set of questions worded in the exactly same way to everyone who takes it, sometimes using follow-up questions to ensure that an answer was understood correctly. So when we initially started our program, everyone in the staff that were involved went through a 2-day training with staff from the Yale School of Medicine. And this was a rather cumbersome, long assessment process. The SIPs took about 2 hours to complete. And so you can imagine it was a difficult thing to get young people to buy into. And the training aspects of it were not really very realistic. So the Yale medical staff went on to develop the mini SIPs, which is a condensed version of this structured interview for psychosis risk syndromes that addresses specifically attenuated psychosis syndrome. It's designed to take about 20 or 30 minutes compared to the 1 or 2 hours that the full SIPs took. The goal of the mini SIPs is to increase availability for clinical settings so that they can use this. So I will be sending out a PDF of this presentation, and I have included the links to the training and the actual mini SIPs assessment for individuals who would want to include this in their own practice. How do you even know, though, that you want to do a mini SIPs with someone? You know, you're in therapy with someone, say, or someone presents for an intake and you're wondering if something is going on that might include this kind of psychosis risk or early psychosis. And so what I usually suggest is by assessing for symptoms by both observing and asking questions. The importance here of thinking about observing is that there are a lot of things that you can't necessarily question someone and get a straightforward answer to, particularly things that involve suspicion or paranoia. And so think about things like asking people if they ever feel like their mind plays tricks on them and getting some additional information. Asking if they ever hear or see things that aren't really there. And as I'm saying this, think about, I mean, each of these things I could tell you, like, yes, there are times where my mind plays tricks on me. There are times where I think I hear someone calling my name. And so, you know, there's some follow-up to this that we're going to talk about. If we ask if someone feels suspicious of others, I actually believe that they're probably going to be suspicious of us. So this is something I really deduce usually from the conversation I'm having about situations that have been going on just when I talk with people about their relationships. Sometimes you can also deduce if an individual is feeling that they're not in control of their own thoughts, if they're wondering whether things are real or imaginary, if that line is becoming blurry, if they're talking about feeling disconnected from themselves or others, and if they're having difficulty with concentration, that might lead to having problems either at school or at work. Considerations when you're asking these things and when you're doing the mini SIPs is the symptom new or worsening? Has it begun or worsened within the last year? Are the symptoms occurring at least once a week in the last month? Is there a better diagnosis that would account for this? For instance, if someone, for instance, recently experienced a significant trauma, say they were mugged on their way home from work when they were taking public transit, and every time they're in that situation taking public transit or near the location where it occurred, they start to have symptoms that look like attenuated symptoms. I would say that that would be more likely part of their post-traumatic stress. If those symptoms begin to generalize and they happen when they're alone in a safe setting, like they are home, we might start to wonder whether those are actually transitioning to being attenuated symptoms. We want to know whether these experiences are causing distress or interfering with the person's functioning. Because if they're not, sometimes we don't want to make a problem when none exists. We want to make sure that they occur at times when an individual is sober. not just at a point when they're under the influence of a mind-altering substance, because then we should be addressing the substance use. And we also want to make sure that they don't occur only at times just prior to falling asleep or just after waking. So, in general here, what I'm saying is if someone says, this has happened to me once, well, it happens to all of us on occasion. Is it something that's happening more regularly, like once a week? Is it getting worse? Is it bothering you? Are you finding yourself thinking about it over and over? That's the kind of consideration we want to take. We also want to take culture and life circumstances into consideration to determine if a symptom is really a more appropriate response based on the person's life. Someone who grew up in a rough neighborhood and is hyper alert because of community violence around them. Well, that might not be suspicion or paranoia. That just might be street smarts. Someone whose family has religious beliefs that kind of verge on like the occult a little bit, more like Santeria, things like that, might have beliefs about spirits or ghosts or other things like that that sound unusual to mainstream culture, but actually not to their particular life and culture. So we want to think about all of these things. We do not want to jump to a conclusion. We do not know exactly how and why psychosis occurs. But what we do know is that symptoms of psychosis are treatable and recovery is possible, which in and of itself is a very important point because 35 years ago, when I started in this field, this is not necessarily what I was taught. It's a new development based on research. We know that psychosocial interventions can be effective and that they require a comprehensive biopsychosocial approach. Medication is important, but also treatment that aims to reduce stress and stimulation and teaches coping strategies to both a young person and to their support network, whether that's their biological family or their chosen family. It's important to actually include those individuals in treatment. The coordinated specialty care model is an evidence-informed treatment model for first episode of psychosis. It is used internationally, and it is the approach that is used here in Illinois in the First.IL program. When we say coordinated specialty care, we're actually talking about one location offering an array of different treatment modalities, therefore making it easy to coordinate a treatment plan that makes sense individually for each client. This includes things like clinical assessment, medication assessment, and ongoing medication management, therapy, and the evidence-informed therapy for first episode is cognitive behavioral therapy for psychosis, which is a combination of a lot of education about psychosis and interventions that help an individual begin to understand that the experiences they're having are symptoms, and then works with them to be able to discern the likelihood that the experience is real or not, like problem solving around whether or how they can tell whether something that's happening that they're experiencing is real or might possibly be a symptom. Peer mentoring, that aspect of having someone with lived experience share how this impacted them and how they responded is very, very important, as is family education and support, essentially sharing information with family members that parallels a lot of the education that's done in that individual therapy work with the client. Education and employment support. We know that getting people on their feet and back functioning, doing things that matter to them is a very, very key component to recovery. Case management, or the ability to provide practical assistance with the day-to-day things that a person might need, and community support, being able to go out and meet with an individual in their natural environment if possible. So these things, I know are more easily provided through a community mental health center that is focused on this versus in a private practice. So we want to think about what can be adapted. First.IL, I think I made reference to it a moment ago, is actually a grant-funded program in the state of Illinois. There are currently 16 different sites scattered around the state that are working with individuals ages 14 to 40 who have had positive symptoms of psychosis at some point in the last 18 months. Unfortunately, in Northwest Illinois, there is not a first.il program. So I know that there are a lot of folks who are experiencing symptoms and looking for help. And I think that might be where people here today are looking for information. So if we're thinking about managing active psychosis, people who might actually have positive symptoms, hallucinations or delusions, the first thing I would say is if a family member or other concerned party calls to refer a client, one of my practices is that I gather as much information about the history and background from this collateral resource before I start engaging with an individual. At this point, I don't have a HIPAA constraint because this person is not my client. I do believe that I have to maintain a very neutral stance, taking into consideration that this is this person's experience. Just as when I meet with the actual client, I need to understand their experience. But it can be very helpful to have a history and information about what others have observed. And so I think that that's a very important aspect. If you try to gather that history with an individual present who's experiencing early psychosis, oftentimes the individual gets very agitated and actually it's off-putting so that you have a difficult time engaging them. If someone is recognized as symptomatic, talk with them to gather information, empathizing with their distress, but not colluding with their delusional thoughts and not challenging their beliefs. So it's a very fine line that you have to walk. You want to ask a person if they're feeling distress and if they want help. And you want to continue to make observations about their behavior, their communication style, and their personal experience and appearance. We want to gauge the degree to which an individual is able to rationalize by asking questions such as, I can see how upset or anxious or distressed you are, and I understand that you believe, like, whatever it is. Oftentimes people will have a very specific complaint, that they're being monitored through their phone, that every time they see a red car that they know it's an FBI agent. It could be many, many different things. So, like empathizing with the idea, telling that you understand that this is something that they very, very wholeheartedly believe, but asking if they might be open to considering the possibility that there could be another explanation. And if the individual is capable, help them define what some different explanations might be. While you're doing this, you want to observe, is this activity calming them? Is it increasing their agitation? We don't want to do things that are going to increase agitation, but it's a way of gauging the level of insight that a person might have and whether you'd be able to start doing some of this CBT for psychosis type of intervention. We want to coach the individual and their support network to minimize stress whenever possible. So for family members, avoiding confrontations or highly emotional exchanges if they can help it. Not forcing people to interact socially if it seems like it's not the right thing. Perhaps avoiding very loud or very bright environments. And definitely discouraging substance use, which can oftentimes make symptoms worse. Occasionally, I've had family members who have offered someone marijuana, for instance, because they thought it might help them. Things like that actually end up making things worse. We want to assess for danger to the self or others, and we want to activate the emergency medical system if necessary to transport an individual to a nearby emergency department. I think it's helpful to ask 911 to send a CIT trained officer, that's a crisis intervention trained officer, if possible, as well as an ambulance versus having someone transported by the police in the back of a police car. I think it's less traumatic to go via ambulance. And, I know that you've probably had to do this for other folks. So the idea of, making sure that family members know that if they want to transport someone, they have to be certain that they don't think the person might run off, things like that. Then we definitely, if the person doesn't actually need to immediately go to the hospital or they probably won't get admitted, we want to refer for a psychiatric assessment. Medication oftentimes can address the acute symptoms, making it easier for you to provide some of the education and other therapy that will be effective. Treatment goals during that risk state, that period when we're talking about the person is not having active psychosis, but that clinical risk state. First of all, is if at all possible to prevent the condition onset. We want to improve functioning and decrease symptoms among those who don't develop psychosis by providing things like therapy to address underlying stressors. Education about psychosis. Medication when warranted, not necessarily antipsychotic medication, but antidepressant or anti-anxiety medications can be very beneficial. So a psychiatrist might need to become involved, but we don't necessarily want to promote the use of an antipsychotic because the person isn't having those symptoms yet. And then for those who do go on to develop positive symptoms, we want to reduce that period of time where the psychosis was untreated. We know that the shorter that time is, the greater the likelihood for better long-term outcomes. That idea of reducing symptom severity and frequency, increasing participation at work and school, and improving quality of life overall. Start with the most basic recommendations. Nutrition, regular sleep, and exercise. Obviously, if someone is experiencing positive symptoms, some of this, like regular sleep, might not be possible. But for many people, education about sleep hygiene and setting up a routine in their life can be very, very beneficial. We also want to talk about stress and how to decrease stress. Sometimes this includes lowering expectations temporarily at school, getting accommodations in place, perhaps reducing a person's work schedule if that's possible. We want to coach them to avoid substance use. We want to help them practice mindfulness techniques and teach those. And we want to definitely encourage them to continue to utilize therapy and mental health treatment. Some of the interventions that you can provide, and that I believe you probably already are providing, but might not think of it with regard to psychosis, include things like stress identification, which I've already talked about. In that idea of that stress vulnerability model, helping an individual to understand that the more resilient they are, the better capable they are to identify stress, perhaps even before it happens, and to navigate around it, or to learn coping skills so that they react to it in a manner that reduces its impact on them, can be so helpful in psychosis treatment. There's a manual that's called Individual Resiliency Training, or IRT. This is a link to it. It's part of the public domain, and it is used in coordinated specialty care models throughout the United States. The IRT manual contains a lot of educational materials, and I encourage individuals to download the PDF and look through that. We do not use it verbatim. I don't believe that most people respond well to something that is simply manualized, but we do utilize particularly the first, I think, 8 chapters, and we definitely use the psychoeducation that is part of IRT. You want to make referrals for medication assessment. You want to address substance use, particularly educating about cannabis risk for those who are vulnerable through the use of motivational interviewing, encouraging people to minimize their use, to use as safely as possible, and if they can, to eliminate use, totally. Really want to provide psychoeducation about psychosis. Also, I'm going to return. I have a little bit more information about cannabis use. There's a couple slides coming up, but I want to make sure I don't run out of time and leave time for questions. So let's talk about psychoeducation. What do I mean by that? I mean discussion on the following: information about mental health and risk. So just talking with individuals so that they understand things like 3% of people in the general population experience psychosis at some point. And if you have a parent or a sibling, your risk might be slightly higher. Help them identify and understand specific symptoms. So teaching people the language to use to articulate what their experiences are and to help them understand what symptoms of psychosis look like. Normalize these things. Make sure that they understand that this is a medical condition that many people struggle with, that they're not alone. Talk about genetic vulnerability. Talk about environmental risk and protective factors. These can be very similar to the way we look at risk and protective factors for suicidal and homicidal ideation. We know that individuals who have a strong support network are better off than those who don't have many people on whom they can rely. We know that people who recently lost their job are at risk, whereas those who have stable work, that's a protective factor. And so helping people to identify risk and protective factors in their environment and then focus in on the things that they're actually able to alter if possible. Some things we can't change. Some things we have the ability to actually alter based on our reaction to it, which follows right into this idea of the stress response and learning coping mechanisms for that. Encouraging family involvement and support system involvement whenever possible, because research shows that those who have a support system involved in their treatment have better overall outcomes. And promote this idea of early intervention rather than waiting to see what happens. Approach treatment as something that's incremental, that, again, can do no harm, that we just want to provide support for the underlying stressors. I know that sometimes this sounds overly simplistic and can be difficult when you have an individual who is perhaps highly symptomatic and delusional. Those individuals likely need to be stabilized inpatient. They need to have the proper medication. We oftentimes do encourage the use of long-acting injections as a means of getting individuals to adhere to recommendations, because it can be very, very difficult to address psychosis with someone who is not able to maintain a routine to even remember to take their medication as prescribed. The reason early identification is so important is you have a much better opportunity to be able to provide therapy that is meaningful and understood by the individual. Once something has been happening for a lot longer, there's a certain percentage of individuals who develop a symptom called anosognosia, where it is not something that they are doing with intention, but neurologically, they are incapable of understanding that the experiences they're having are symptoms. And that is, I don't remember what the actual percentage is, but a certain percentage of people with psychosis do experience that. And I know you probably all have had interchanges with those individuals. CBT for psychosis and clinical high risk are the evidence-informed approaches that decrease symptoms and promote better symptom management. So, it's partially that same formulation that we're all familiar with, that connection between thoughts, feelings, and behavior, underlying depression and anxiety, exploring and testing beliefs about oneself and environment that includes the actual beliefs around delusional thoughts, and then generating alternative explanations for those. One of which must include the idea that you might be struggling with a medical condition that causes you to have these experiences. Cannabis use in and of itself does not actually seem to cause psychosis. There are many people who use cannabis that don't have symptoms, but there is significant evidence that exists that there's a correlation between cannabis use and the onset of psychosis for those with a biological vulnerability. The problem is we don't all know who has the biological vulnerability. Sometimes we do, and sometimes we don't. Um, we really, at Thresholds, encourage a harm reduction approach, this idea to use less, to use safely, and if possible, to eliminate use altogether. We know that cannabis use among individuals with psychotic disorders can make symptoms worse and can trigger a relapse. The average age of onset for psychosis among cannabis users is almost 3 years younger than those who don't use. Therefore, as you might imagine, that interrupts completion of school, graduating from high school, a lot of things among people who are using cannabis consistently. We know that stopping use after a first episode can improve recovery, and that as opposed to THC, which is the psychoactive ingredient in cannabis, CBD, which is a non-intoxicating cannabinoid, shows some promise for improving psychotic symptoms. So no to THC, but CBD can be okay. What can you do? Well, increasing awareness of psychosis and psychosis risk is very important. You're here today learning about this. Please pass this information along to families as well as other mental health providers. Remember that we need to first always rule out both medical problems and primary substance use problems before jumping to the conclusion that this is a psychotic disorder. We want to remember to integrate those questions into our practice, particularly with individuals that we are treating who have acute depression and anxiety. We want to consider that there's the possibility that what we're seeing are negative symptoms and not depression. So continue to ask those questions and make observations. We want to integrate the coordinated specialty care strategies into therapy practice whenever possible. Utilize the IRT manual and create a platform for how you might present education about psychosis to individuals who might be experiencing early symptoms and to those who are at risk. And continue to educate others and fight against mental health stigma. Thank you so much. This is my contact information. And at the end of this presentation, there are also a number of slides that have additional resources if you are interested in learning more about early psychosis intervention and the clinical high risk state. Any questions? I managed to do it in 55 minutes.
Thank you very much, um, Eva. Let's see. We don't have any questions in the Q&A, but I do want to tell people if they have any open questions or things they want to ask about, you can put them into the Q&A box um, at the bottom of your screen. Very informative. We are going to be posting the recording on our YouTube channel. Also, you mentioned that a PDF of the slides of the prior presentation, and this one also would be available.
I sent the prior one to Danielle 2 weeks
Okay.
ago, and I will send one to this one. This is a slightly altered version, so I will send this one as well.
Okay, and we'll have links to that in the description of the video. Now, I mentioned CEUs being available for this presentation, being available in response to the evaluations that we will be returning or that are returned to us. Those CEUs will be provided courtesy of Rosecrans. And let's see if there are no open questions. I want to thank you, Eva, for your brilliant presentation.
You're welcome. Thank you so much for having me. I also want to remind people that in the presentation there are those links to both the mini SIPS evaluation, the mini SIPS training, and the IRT manual, which I think are very useful resources.
All right. And since we have a moment or two, I want to remind everybody that we have uh, an event this evening. It's called Clay Your Stress Away. You can look at the NAMI Northern Illinois website for information about that. And you mentioned things about reducing stress factors. Perhaps we can have you come on and tell us more about those in the future, Eva.
Yeah. I think that that's something that addresses, like no matter what you're struggling with, we benefit from that. But it's a huge factor in underlying issues with psychosis. And so sometimes helping to frame it that way makes a big difference in terms of helping individuals recognize where they might actually have some control.
Right. And we know that there are quite a few families who are wondering what they can do. And you've given some great suggestions for therapists and family members alike. So once again, I want to say thank you to you and to all of the people who have participated in our webinar. And we look forward to engaging sessions like this in the future. Thank you so much, Eva.
You're welcome. Have a great afternoon.
You too. Thank you, everyone. We'll see you next time on Leading the Conversation.